Today, we will talk about analgesics and their structure-activity relationships. So what are analgesics? Analgesics, or pain relievers, are medication that reduce inflammation or alter the brain's perception of pain without loss of consciousness. They are used to manage various types of pain, including those from surgery, injury, headaches, arthritis, and chronic conditions. Analgesics can be available over the counter or require a prescription. They can classify into opioid analgesic and non-opioid analgesics, just like NSAIDs and paracetamol-like drugs. Moving forward to the classification of analgesics. First, we have the opioid analgesics. Opioid analgesics primarily act on opioid receptors in the central nervous system and gastrointestinal system, producing effects including analgesia, respiratory depression, sedation, and constipation. Opioid analgesics are frequently used to treat moderate to severe pain. The second one is the non-opioid analgesics, including acetaminophen or paracetamol and NSAIDs. Acetaminophen and NSAIDs are often effective for mild to moderate pain. Non-opioids do not cause physical dependence or tolerance. Now, let's talk about the structure-activity relationship, or SARs. Structure-activity relationship, or SAR, is the relationship between the chemical structure of a molecule and its biological activity. Its studies aim to identify the specific structural characteristics of a compound that are associated with its biological activity, such as enzyme inhibitory activity, antimicrobial activity, and toxicity. Fentanyl, a potent opioid agonist, was developed in the 1950s to fill a need for strong and rapid analgesia. Because of these characteristics, fentanyl is commonly used to treat chronic cancer or in anesthesia. Fentanyl is related to other opioids like morphine and oxycodone. Fentanyl was FDA approved in 1968. This is the drug structure of fentanyl. Its chemical formula is C22, H28, and 20. Its IUPAC name is N-phenyl-N, 1,2-phenylethylpiperidine, 4-YL-propanamide. Next is the core structure and functional groups of fentanyl. First, we have the N-phenylpropanamide moiety. This segment includes an amide linkage connecting a phenyl ring to a propyl chain. This is important for binding to opioid receptors, facilitating the drug's analgesic effects. The second one is the piperidine ring tertiary amide, a saturated 6-membered nitrogen-containing heterocycle. This enhances lipophilicity, aiding in the rapid crossing of the blood-brain barrier and contributing to fentanyl's potency. Lastly is the N-phenylethyl group, a phenyl ring attached via a nitrogen atom of the piperidine ring. This increases affinity for the U-opioid receptor, enhancing analgesic potency. These functional groups collectively enable fentanyl to bind effectively to opioid receptors, resulting in its potent analgesic effects. We also have the structure-activity relationships features of fentanyl. First, we have the piperidine ring, essential for opioid activity. The nitrogen in the piperidine ring interacts with aspartate residue in the mu-opioid receptor, which is essential for activation. Fentanyl primarily binds to mu-opioid with high selectivity over kappa and delta opioid receptors. The next one is the N-phenylethyl group, enhances binding affinity. The phenylethyl group moiety increases lipophilicity, allowing fentanyl to cross the blood-brain barrier rapidly and exert strong analgesic effects. This enhances mu-opioid receptor selectivity by improving hydrophobic interactions within the receptor's binding pocket. The third one is the amide functional group, improves receptor fit. The amide group contributes to hydrogen bonding interactions, further stabilizing fentanyl within the receptor, plays a role in differentiating fentanyl from other opioids by increasing receptor binding specificity. The last one is the lipophilicity, a key to rapid onset and potency. Fentanyl's high lipophilicity allows for rapid penetration into the central nervous system, or CNS, leading to fast and potent analgesic effects. Fentanyl has a shorter duration of action compared to morphine due to its rapid redistribution from the CNS to peripheral tissues. So the mechanism of action of fentanyl is that fentanyl binds to opioid receptors, especially the mu-opioid receptor, which are coupled to G proteins. Activation of opioid receptors causes GTP to be exchanged for GDP on the G proteins, which in turn regulates adenylate cyclase, reducing concentrations of CAMP or COMP. Reduced COMP decreases COMP-dependent influx of calcium ions into the cell. The exchange of GTP for GDP results in hyperpolarization of the cell and inhibition of nerve activity.
First example of analgesic is codeine. So codeine is a well-known opioid analgesic that was first approved for medical use in the United States in 1950. It is commonly used to relieve mild to moderate pain and is often combined with other analgesics such as acetaminophen or ibuprofen to enhance its pain-relieving effects. Unlike stronger opioids, codeine has a lower risk of causing sedation or impairing consciousness, making it a safer option for pain management. Codeine is classified as an opioid because it is derived from the poppy plant. It's a Papaver somniferum belonging to the family Papaveraceae. For the drug structure of codeine is C18, H21, and NO3. For the 5A, 6A, 7A dihydro, 4,5-epexo, 3-methoxy, 17-methylmorphinan 6-O. And for the core structure and functional group, first is aromatic ring. The aromatic ring in codeine-phobic interaction with opioid receptors. These interactions enhance the binding affinity and specificity, which are vital for codeine's ability to relieve pain effectively. Second is methoxy group. The presence of the methoxy group reduces the overall polarity of the molecule. This reduction in polarity improves the codeine's ability to cross the blood-brain barrier, increasing its bioavailability and analgesic potency. Then third, functional group is phenolic hydroxyl, the OH group. The phenolic hydroxyl group plays an essential role in hydrogen bonding with opioid receptors. This interaction enhances binding strength, contributing to codeine's overall analgesic effect. The fourth functional group is tertiary amine group, the NCH32. The tertiary amine group is responsible for ionic interactions with the opioid receptor's ionic sites. These interactions help in receptor binding and activation, which is critical for codeine's pharmacological activity. Then fifth is ether linkage, the ROR. The ether linkage helps maintain conformational stability of the molecule. This stability influences codeine's binding with biological targets and affects its metabolic stability, making it more resistant to breakdown. 6. The cyclohexane ring. Cyclohexane ring provides structural rigidity to codeine. It maintains the molecule's three-dimensional shape, which is necessary for proper receptor binding and pharmacological effects. And then for the SAR feature, first is methoxy group, the stability and selectivity. The presence of methoxy, the OCH3 group in codeine reduces its affinity for M-opioid receptor compared to morphine. Morphine, which has hydroxyl OH group, instead binds more strongly to the receptor, resulting in higher analgesic potency. Because of this, codeine is less potent than morphine but more stable, allowing it to be orally administered with fewer side effects. Then, the hydroxyl group, or the OH receptor, or the OH receptor binding and hydrogen bonding. The hydroxyl, or OH group, is crucial for receptor binding and activation through hydrogen bonding with the opioid receptor. Chemical modification and disposition, such as acetylation, can alter the analgesic properties of the compound. For example, is 6-acetylcodeine has been studied for its pain-relieving effects, showing potency similar to codeine but with different effectiveness. At the double bond between C7 and C8, the rigidity and receptor fit. The presence of a double bond between carbon 7 and carbon 8 affects the structural rigidity of the molecule. Studies indicate that saturating this double bond is linked to an increase in opioid agonistic activity. This suggests that reducing the double bond enhances the binding efficiency of the molecules to opioid receptors, leading to improved analgesic effect. And then the tertiary amine, NCH3, receptor interaction and antagonist activity. The tertiary amine group is crucial for M-opioid receptor activation, influencing the agonist or antagonist activity. Modification to this group, such as adding an N-allyl or N-cyclopropamethyl substitution, can convert the molecule into antagonist or partial agonist. This means that altering this structure could reduce or completely block the analgesic properties of the drug, which is a strategy used in opioid antagonist development. And next is for the MOA of codeine. So the MOA of codeine is that the hepatic metabolism and conversion to morphine. So after administration, codeine undergoes metabolism in the liver. Around 5 to 10% of codeine is demethylated by the enzyme CYP2D6 to form morphine, which is potent M-opioid receptor antagonist. This conversion is critical as morphine is responsible for the most codeine analgesic, pain-relieving effects. Then for antitussive or cough suppressing effect, codeine itself has mild affinity for opioid receptors, which contributes to its ability to suppress cough. This is why codeine is often used in dry cough syrups for persistent dry cough. The next is genetic variability and individual response. The effectiveness of codeine varies among individuals due to genetic polymorphism in the CYP2D6 enzyme. So, some individuals are ultra-rapid metabolizers, meaning they convert codeine to morphine very quickly, leading to a stronger effect and increased risk of side effect. Others are poor metabolizers, meaning they convert very little codeine to morphine, resulting in reduced pain relief.
Paracetamol, also called as acetaminophen, is a common pain reliever and fever reducer that is available without a prescription. It is widely used for treating mild to moderate pain, such as headaches, toothaches, muscle aches, menstrual cramps, joint pain like arthritis, cold and flu-related fever. Paracetamol is sold under various brand names including Panadol, Calpol commonly used for children, Alvedon, and Tylenol. So this is the drug structure. It is also known as N4-hydroxyphenyl acetanamide and N4-hydroxyphenyl ethanamide. So next is the core structure and functional groups. So we have aromatic benzene ring, enhances molecular stability and drug receptor interactions. Amide CoNH plays a role in its analgesic and antipyretic effects, and we have hydroxyl OH, increased solubility and affects drug activity. So next is the SAR feature. Aromatic benzene ring, activity and selectivity. Unlike NSAIDs, paracetamol does not strongly inhibit COX-1 and COX-2 in peripheral tissues, reducing its anti-inflammatory effects, but making it safer for the stomach instead. It preferentially acts on COX-3, a brain-specific isoform, which enhances its selectivity for pain and fever reduction, without causing gastrointestinal side effects. So we have hydroxyl OH group, solubility and reactivity. The para-hydroxyl OH group increases the molecule solubility, which improves absorption and bioavailability. It also plays a role in modulating interactions with CoX enzymes. Next is the amide CoNH group, analgesic and antipyretic activity. It stabilizes the molecule, making it less reactive than other phenolic drugs, reducing side effects. The amide bond prevents excessive metabolism, extending the drug duration of action. Next is the lack of carboxyl COOH group, selectivity and safety. Unlike the NSAIDs, paracetamol lacks a carboxyl COOH group, which means it does not significantly inhibit COX-1 in the stomach. This structural difference makes paracetamol safer for the gastrointestinal tract compared to aspirin or ibuprofen, which can cause ulcers. And now let's go to its MOA. Paracetamol works by blocking COX-2 enzymes in the brain, which reduces pain and fever. However, unlike NSAIDs, like ibuprofen, it does not reduce inflammation because it has a little effect on the rest of the body. This makes it useful for headaches, fever, and mild pain, but not for swelling or joint inflammation.
Aspirin. It is an acetylic acid, also known as aspirin. It is commonly used as a painkiller to treat pain, fever, inflammation, and migraines, as well as to reduce the risk of heart attacks, strokes, and other events. It has both anti-inflammatory and antipyretic effects. It means it reduces fever. This drug also inhibits platelet aggregation and is used in the prevention of blood clot, stroke, and myocardial infarction. So the drug structure of the aspirin is C9H8O4, which commonly known as the 2-acetyl-oxybenzoic acid. So next, we're going to talk about the core structure and functional groups of aspirin. So first, we have here the carboxylic acid group, which contributes to the molecular acidity and plays a crucial role in its inflammatory properties. So the function of carboxyl group is it plays a role hydrogen bonding, affecting solubility and reactivity. So in the body, the carboxyl group ionizes, contributing to aspirin's ability to enzyme inhibits in COX. So next, we have ester group, which enhances the molecule's lipophilicity, facilitating its absorption in gastrointestinal tract. So the ester reduces stomach irritation compared to salicylic acid, making aspirin easier to tolerate. It is also responsible for aspirin's irreversible inhibition of COX enzyme as it transfers its acetyl group to a serine residue in the active site of enzyme. So ester also prevents prostaglandin synthesis, leading to reduced pain, fever, and inflammation. And we have here the last one, the aromatic benzene ring. It serves as the backbone of which the carboxylic acid and ester group are attached, influencing the molecular reactivity and interaction with biochemical targets. So it provides function, stability, and lipophilicity, which helps aspirin cross biological membranes easily. It also helps aspirin bind to active sites of enzyme and interact with the other target proteins. So we will move forward to the structural activity relationship feature of the aspirin. So first, we have here the acetyl group. It is key for irreversible CoX inhibition. So the acetyl group is a defining feature of aspirin. So it is responsible for irreversible acetylcysteine, the SIR530 residue of CoX and SIR516 of CoX2, leading to permanent enzyme inhibition. So this prevents the formation of prostaglandin, so responsible for pain and inflammation, and thromboxane A2, which involve in platelet aggregation of clot formation. So we have here the carboxyl group, which is important for CoX binding. So the carboxyl group is crucial for enzyme binding and inhibition. It forms ionic interactions with amino acid residues in CoX enzyme. So it blocks the active site and preventing the production of prostaglandin. So next, we have here the aromatic benzene ring, which is essential for activity. So the benzene ring serves as the pure structure, providing hydrophobic interaction that help aspirin bind to CoX enzyme. So any major modification of removal of the benzene ring destroys the activity. So the last one, we have here the ester group. It is linkage for solubility and absorption. So it is essential for aspirin's unique mechanism of action. So it irreversibly accelerates the residues, which is the SIR530 for CoX1 and 516 for CoX2, permanently deactivating the enzyme. So this prevents the prostaglandins and thromboxane synthesis, reducing pain, inflammation, and platelet aggregation. So removal of modification of this group, for example, converting it into the hydroxyl group, reduce CoX inhibition and make the drug less effective. So I'm going to talk about the mechanism of action of aspirin. So aspirin works by irreversibly blocking CoX enzyme, which produce prostaglandin, cause pain, fever, and inflammation, and thromboxane A2, which helps blood clotting. So how it works? First, pain, inflammation relief inhibits CoX2, reducing prostaglandins, which lowers pain and swelling. Fever reduction stops prostaglandins from affecting the brain's thermostat that reduce fever. So third, we have here it prevents blood clots. So it blocks CoX1 in platelets, stopping thromboxane A2 production that prevent blood clot formation. Since aspirin permanently blocks CoX1 in platelets, it stop thinning effects last 7 to 10 days, making it useful for heart disease prevention.
Ibuprofen is a non-steroidal anti-inflammatory drug, or NSAID, derived from propionic acid, and it is considered the first of the propionics. Ibuprofen is the most commonly used and prescribed NSAID. It is a very common over-the-counter medication, widely used as the analgesic, anti-inflammatory, and antipyretic. Here is the drug structure of ibuprofen, or C13H1802, or RS2,4,2-methylpropyl phenyl propionic acid. Then we have core structure and functional groups. First, we have carboxylic acid group. It is essential for ibuprofen's anti-inflammatory properties. It interacts with cyclooxygenase or COX enzymes, inhibiting the synthesis of prostaglandins, which are mediator of inflammation and pain. Then we have aromatic benzene ring. It provides structural stability and facilitates the drug's interaction with hydrophobic regions of the COX enzymes, enhancing its binding affinity. Then we have isobutyl side chain. It increases the lipophilicity of ibuprofen, adding in its ability to cross lipid membranes and reach its site of action effectively. Then we have the SAR feature. First, we have carboxyl or COOH group or COX enzyme inhibition. It forms hydrogen bonds with arginine residues in the active site of COX1 and COX2, stabilizing the binding and inhibiting prostaglandin synthesis. Non-selective, but COX1 inhibition is slightly more pronounced, contributing to gastrointestinal GI effects. Then we have aromatic benzene ring or rigidity and COX enzyme interaction. It facilitates hydrophobic interactions with COX enzymes, increasing drug binding affinity, non-selective for COX1 and COX2, but plays a role in anchoring the molecule within the active site. Then we have isobutyl side chain, solubility and binding affinity. It enhances hydrophobic interactions with COX enzymes, stabilizing ibuprofen within the binding pocket. No significant selective no significant selectivity. It contributes to the drug's lipolicity and system absorption. Then we have chiral center or SNR ibuprofen forms. As ibuprofen is 100 times more potent than R-ibuprofen in COX inhibition. However, R-ibuprofen undergoes metabolic conversion to S-ibuprofen in vivo, non-selective for COX1 and COX2, but the conversion process may influence duration of action. Then we have the mechanism of action. Ibuprofen is an NSAID and thus it is non-selective inhibitor of cyclooxygenase, which is an enzyme involved in prostaglandin, mediators of pain and fever, and thromboxane, which is the stimulator of blood clotting, synthesis via the arachidonic acid pathway. Ibuprofen is a non-selective COX inhibitor and hence it inhibits the activity of both COX1 and COX2. The inhibition of COX2 activity decreases the synthesis of prostaglandins involved in mediating inflammation, pain, fever, and swelling, while the inhibition of COX1 is thought to cause some of the side effects of ibuprofen, including the GI ulceration.